So as I mentioned before, whenever we release nitrogen from the actual amino acid, we're going to form ammonia, which can be toxic to the body, or which is toxic to the body. So we have to have a way to be able to dispose of that ammonia. Here again, you're going to see glutamate dehydrogenase. Glutamate just has a role of being able to help us get rid of that ammonia. Ammonia, or urea, is synthesized by the liver and the kidneys primarily through the urea cycle. Okay, one of your questions on your chapter questions is going to ask you that first step in the urea cycle. So you'll be able to read a little bit about that. So talking about protein requirements, basically these are going to be based on nitrogen balance. So remember, nitrogen is that important component of amino acids that separate amino acids from other macronutrients. So what we want is an equilibrium between the nitrogen we consume and the nitrogen that we put out. Nitrogen balance, or we can have a positive nitrogen balance and we can have a negative nitrogen balance. Basically, positive nitrogen balance is going to occur whenever our body is building up tissues. So pregnancy would be a good example here. Also, infancy and early childhood would be an example here. Negative nitrogen balance is whenever we are using protein in our body as energy sources. So an example of that would be somebody under severe trauma or metastatic cancer, somebody who's expending more energy than what they're consuming, basically. So we can determine our nitrogen requirements through several means. Nitrogen balance method is often consumed and kind of easy if you have the right equipment. You have to be able to estimate how much nitrogen is consumed and then be able to estimate or calculate how much nitrogen is being put out by that patient. So that can be done by lab work if someone were to order it. The factorial method is another way. It just measures obligatory nitrogen losses, which would be through like sweat, urine, feces, etc. So don't worry about that. Okay, so the RDA specifically, the RDA for protein is currently set at 0.8 grams per kilogram. So in a typical normal healthy person, this is what we would estimate their protein needs to be. And what this RDA means is that that's the amount of protein which would provide the amount of nitrogen to achieve nitrogen equilibrium or nitrogen balance. Of course, this can differ from person to person. This is just a set kind of generalized recommendation. So you have to use clinical judgment whenever you're estimating protein needs for specific people with specific conditions. Alright, so we have our amino acids. We talked about our essential and non-essential amino acids, but some amino acids are also important in, like I said, creating other amino acids. So, for instance, or creating other substances, period, I should say. So, for instance, tryptophan is important for us to consume because it helps us to create niacin, as well as serotonin. Methionine and lysine are important for the creation of carnitine. And serine is important for choline. So we have to be able to consume these in adequate amounts. So what happens if we do have a low protein intake? Is our body going to adapt to that? Of course it will. So there's some key ways that our body is going to adapt to this. We're going to stop oxidizing amino acids as much, so we're not going to break down amino acids as quickly and efficiently. We're also going to decrease how well those oxidative enzymes work to be able to decrease amino acid oxidation. And then we're going to make the urea cycle not work as efficiently as well. So we're not going to be breaking down amino acids to create ammonia or to create urea as readily so that we can conserve protein. So we can't talk about amino acids without talking about inborn errors of metabolism. So these are important because certain people may have defects in being able to break down certain amino acids, and these can lead to diseases or conditions that may even be irreversible. PKU is one of those. They don't have the enzyme to break down phenylalanine, and that can cause it to be built up in the blood and can cause severe mental issues, more so like severe mental handicaps, I should say. So take a look at your book and review those amino acid inborn errors of metabolism. You're gonna do that in your assignment as well. Okay, so our branched chain amino acids, this is kind of a hot topic, especially in sports nutrition. And there is some research about branched chain amino acids and their benefits. So our branched chain amino acids are leucine, isoleucine, and valine. There is a good bit of research specifically about leucine among the branched chain amino acids. But what they find is that incorporated with a calorie controlled diet and with a diet adequate in complete proteins, with the addition of branched chain amino acids to those two circumstances, they can increase lean body mass, they can decrease adiposity, and they can decrease body weight. But like I said, you have to be able to consume a calorie-controlled diet that is sufficient in complete proteins. Leucine particularly can help with this if consumed at adequate amounts. So you'll see here they make the recommendation for 7 grams of leucine a day, but also 2.3 to 2.8 grams of leucine at each meal. So this is something you'll see often with protein or amino acid recommendations, that you can't just bulk it up at one meal and not have it in others. With cancer patients specifically, there's a lot of research that suggests that they eat about 30 grams of protein 3 times a day spaced out as you would have like your breakfast, lunch, and dinner. And what that helps is to keep protein coming in specific increments throughout the day so that you're not having breakdown or protein tissue breakdown at the times of the day whenever you're not consuming adequate amounts of protein. With our branched chain amino acids and how they affect body composition, the mTOR pathway is specifically important because it helps to stimulate muscle protein synthesis. Don't worry about the second notch here, but the mTOR pathway is important. So I did mention our limiting amino acids earlier. Commonly, if something isn't considered a complete protein or high biological value protein, it's because of these limiting amino acids, which is lysine, methionine, cysteine, threonine, or tryptophan. One example would be collagen peptides, or gelatin. These have good protein content to them, and they can be beneficial, regarding some research, but they are inadequate. They do provide some of these essential amino acids, but not in amounts adequate. I think it's methionine that is inadequate. It might be tryptophan. But usually if we have a limiting amino acid, it's going to be one of these. So some people think or have the question, I can't have too much protein, right? Protein is kind of a hot food right now. Protein's added to chips, to drinks, to coffee, all kinds of stuff. But there is some concern that excess dietary protein can be harmful, especially to our kidneys. You'll see in your MNT class how protein affects renal status, especially in those people with renal stress already. But there's also some idea that it can affect our bone mineralization, and then also increase our incidence of colon cancer and obesity. Colon cancer, I think, is probably more related to the sources of protein. So if we're eating more plant proteins or incomplete proteins, we're going to be consuming at the same time probably more fiber. If we're consuming a high protein diet from a lot of animal sources of protein, of course, that's going to be a lot different and could increase the risk of colon cancer. Also, we have to think of our processed meats and how they affect our cancer rates as well. That would go in with obesity as well too. Okay, so protein's important with our nutrition. Kwashiorkor and marasmus are things that we see typically not in the United States or developed countries, but also, but more so underdeveloped countries. What we would see here in the United States is protein energy malnutrition or protein calorie malnutrition. This is something you'll see in your clinicals or working in the hospital. But basically what this means is somebody's either not consuming enough energy, or they're not consuming enough energy or enough protein. And you'll see in these slides how these differ a little bit. So if you recall at the beginning of this, I mentioned how protein helps to maintain our fluid balance. So if we don't have adequate protein to keep fluid in our cells, what will happen is that fluid will leak out into the extracellular fields, and that can cause swelling or edema. So in kwashiorkor, which is an insufficient protein intake, we'll see this pot belly and we'll see this moon face, and partly that is because of that edema. Other signs are easily pluckable hair, hair that's not as colored as it used to be, skin lesions, and fatty liver, as well as these signs. And these are something that you'll learn too whenever you start doing the nutrition-focused physical exam. So in contrast, marasmus is more of the combination of inadequate calories and inadequate protein. So here you'll see emaciation or muscle wasting, minimal body fat, and they look thin already. So what you would see, kwashiorkor, an example would be, or something that you would always kind of commonly think of is like a child in the desert, right? That has the big pot belly, the moon face. They don't look like they're malnourished, but they're actually severely protein malnourished. They're getting probably a decent amount of calories, but they're not getting enough protein to keep that fluid balance. Whereas marasmus, you might think of like somebody who was in the Holocaust, right? They didn't have enough protein, but they also didn't have enough calories. So their body was using those reserves, those fat reserves and those muscle reserves as energy, and that's what results in emaciation. So something you'll also see often in your clinical practice, unfortunately, is sarcopenia, and this is a loss of muscle mass and muscle strength. It's commonly seen in older patients or age-related sarcopenia, and that's just like what naturally occurs due to age. But it can also be because of lack of exercise and inadequate protein intake, or even through cancer and heart disease. So to prevent that, we'll usually go above this RDA up to 1.2. 1.5 is something I would even give patients with cancer-related sarcopenia as well. So clinical judgment, again, like I said. But weight-bearing exercise is also really important in addition to the protein intake, because if we're not using those muscles and exercising those muscles, we're not going to be able to save them or grow them. So we have to have weight-bearing exercise along with the protein intake.